I actually think, in terms of, and I'm not, in this particular statement, I'm not saying I'm speaking for CARF. I'm just saying as somebody who has spent, 40 years working in this business, um, I welcome, these tools that are helping clinicians because you and I have both been in situations where we've been, running large systems of people, and it's a real challenge to be able um, to smooth out quality in an organization, right? You have different skill sets for individuals. If you're employing, 300 or 400 clinicians, they're not all the same in terms of their skill sets. Some people are really good in some areas and weaker in others. One of the things that I think that these tools are going to help is to level that playing field that, even if I'm not as good in a particular, at recognizing a particular symptom or clusters of symptoms, this is going to help to put it in front of me. And I think about, we've been doing a lot of work, and I'm kind of working on an internal project now for the Action Alliance for Suicide Prevention, because we've made several changes to our standards trying to align things around the zero suicide framework. So I'm looking at results, what has been happening in terms of the conformance to those standards over the years that we've been making these subtle changes to the standards. And, there are a lot of individual cues that a person might present with that can be reflective of suicidal thinking that is completely missed by the clinician because it happens over 3 or 4 or 5 sessions, perhaps, but I don't know that it would get past. I'm hoping that that's the kind of value that we get, right, is that it doesn't get past this augmented intelligence, as you say, right, that says, hey, this person has mentioned this particular thing that is risky multiple times, and maybe it's something that there needs to be some more exploration about. Now, that's going to still be left to a clinician to do, but it informs them in ways that perhaps they wouldn't have been informed because they're busy